Good day, everybody. Greetings. I'm Catherine Latimer from the John Howard Society of Canada, and we want to welcome all of you to this John Howard Society event. It is our week for recognizing John Howards across the country and for some of the work we do, and we're very happy that you were able to join us for this. Before we get on with the virtual conference today that'll focus on the challenging issues of mental health in the criminal justice system, just a couple of housekeeping matters before we begin. One is that the cameras and mics will be off, and there will be breakout sessions after the formal panel to allow for more feedback and suggestions from participants. If you can join us for those, please just don't sign off after the plenary terminates, and you will be sent to a room, which is great. There were a few technical issues yesterday, and if you're having difficulty speaking or being recognized in one of the breakout sessions, then please raise your hand. Apparently that triggers the ability for you to be able to be heard by everyone else, which is great. It is now my pleasure to introduce the moderator for today, Sheila Wildman. She's a professor at the Shulamith School of Law. And as you can see by the biographical material that was sent out, she has a strong interest in terms of her research in health, in disabilities, and in prisons, and we're very pleased that Sheila could take the time from a very difficult week for her to join us today. Over to you, Sheila. Thank you.
Thank you so much, Catherine. It's really an honor to be involved in this session. I'm excited to get started. I just want to start by saying, yes, I'm on faculty at the Schulich School of Law here in Nova Scotia, which is also on the unceded territory of the Mi'kmaq, Wolastoqey and Passamaquoddy peoples, sovereign nations holding inherent rights as the original peoples of these lands. So I start this panel in the spirit of reflection on those inherent rights and the legacies of colonialism evident in our prisons. As I said, I'm so honored to be moderating this important panel, which invites us to think carefully and creatively about how Canada, the provinces, our communities, all of us can do better to support the needs and human rights of persons with mental health disabilities and often intersecting forms of marginalization, including indigeneity, who are criminalized and incarcerated in Canada's prisons and jails. Just a word, sessions like this, I feel, are of such value, not just for deepening our understanding of mental health services in different jurisdictions, across disciplines, in different institutions, different sectors, but for making connections across those spaces from our different vantages to ask how we can do better to support and most ambitiously and fundamentally prevent criminalization and incarceration of folks with mental health problems. Also, how to respond to or avert the deterioration of mental health that occurs inside prisons, and how to achieve continuity of care when people leave prisons and return to communities. So this panel will explore these questions in all of an hour and inspire us to explore solutions. Let me just quickly say a word about the panelists you are about to be treated to. So first up, we will have a pair of panelists, Dr. Christopher Canning with Waypoint Mental Health Center and Sandra Coppert, who is Director of Mental Health Advancement with the Mental Health Commission of Canada. Both will be presenting on the Mental Health Commission of Canada's soon to be released Criminal Justice Action Plan. So that will be about a half an hour for that presentation or co-presentation. Then we will hear from Jeanette Clark, who is Manager of Institutional and Community Mental Health Services with the Correctional Service of Canada. And Jeanette will speak to mental health services in Canada's federal prisons. And finally, we will hear from Riley Hunt with the John Howard Society of Newfoundland and Labrador, who will be presenting on the New Day program, which is a through the prison gate into the community program to help those with mental health disabilities leaving prisons. So that, as you know, is our panelist lineup. And after that, as Catherine said, there will be space and time for breakout sessions for feedback and discussion. I'll be leaving just before that, but I'm so hopeful that you'll be able to stay in order to participate in the conversation. So I'm going to step back now and open the floor to Sandra and Christopher, Dr. Canning. Thanks.
Great. Thank you so much. And we're just, we already have the slides up here that we'll be speaking to. And I was just looking to see if, great, we have Christopher there as well. So thank you so much, Catherine, and of course, the John Howard Society for inviting us to join this virtual session. It's great to see such turnout for today. So pleased to have the opportunity to speak to you about work that we're leading to develop a national action plan on mental health and criminal justice. And with that, Christopher and I are joining you from the traditional and unceded territory of the Algonquin Anishinaabe peoples, which is part of contemporary Ottawa. We're grateful for the opportunity to connect with you here virtually and enjoy to live and work on this land. And with our recognition, we endeavor to infuse cultural safety and humility into our work and ensure the voices and experiences of Indigenous peoples are heard and listened to, and that their perspectives are reflected in the development and implementation of the Action Plan on Mental Health and Criminal Justice. So we were already introduced, but you'll be hearing from both Christopher and myself. I'll just be kicking things off, myself on behalf of the Commission and working directly with Waypoint Center for Mental Health Care through so much of the great research and development of the action plan that they've been supporting us with for quite some time now. And with the time we have with you today, we're just going to look high level at what the issues are. I'm sure you can inform us just as much in terms of the issues, why it matters, and explain how the work that we've been building has led to the development of a national action plan, and then highlight where we're at now with this work and lead into a discussion later, as mentioned. So just to give some background context, the Mental Health Commission of Canada's work in mental health and law began about 2012, and that was following the release of the Mental Health Strategy for Canada, so a much broader strategy in support of mental health in Canada that came with a number of recommendations and priorities to guide not only us at the Commission and others in terms of priority areas of focus to move forward in. And with that, acknowledging that priority 2.4, to be specific, provided the broad direction, for Canada to reduce the overrepresentation of people living with mental health problems and illnesses in the criminal justice system, and to provide appropriate services, treatment, and supports to those who are in the system. So our role has been since then to work with experts and partners to really figure out how best to go about addressing this priority, knowing that there's various realities, limitations, but also opportunities to do so. So just very broadly over the years, and since, as I mentioned, the release of the Mental Health Strategy for Canada, our work in mental health and law has evolved. Some areas here on the slide, some of you may be familiar with, but then certainly starting in 2019, we had additional focus and support to better understand mental health and criminal justice as a focus area, starting for us as a scoping project to really get an understanding of current realities and issues, identify gaps and barriers in mental health and criminal justice to understand where we as a commission could potentially amplify, support, or even lead work in this area. So with that scoping review, we then hosted a national forum in March 2020, which was a big moment in time for everyone just before kind of the world shut down. But with that, we heard from expertise across Canada on this topic about the need to do more, to have a concentrated effort, and that the Commission was welcomed and well positioned to take a leadership role in the need to develop a national action plan on mental health and criminal justice. And so with that, what are some of those issues that are driving this work? And it's that we know from the scoping review that about 73% of federally incarcerated men and 79% of federally incarcerated women in Canada meet the criteria for one or more current mental disorders. We also know that certain priority populations, as we refer to them, are overrepresented in the criminal justice system, and that includes First Nations, Inuit, and Métis peoples, who represent about 30% of the incarcerated population, despite only making up about 5% of Canada's population overall. Also, the African, Caribbean, and Black communities, who account for about 9% of the total incarcerated population in federal corrections, despite representing about 4% of adults in Canada. We also know that people who work in the criminal justice system experience unique challenges, such as exposure to unsafe working conditions and violence, and that this can, of course, have a significant impact on the psychological health and safety in the workplace. And from our 2019 report, it highlighted that public safety personnel, including correctional officers, dispatchers, and police officers, are almost 4.5 times more likely than the general population to experience symptoms of mental disorders. So from this data, we could definitely see that there was a lot of work to do to reduce overrepresentation and improve the mental health outcomes of everyone involved in the justice system. So quite a large undertaking, and it's certainly not something that the commission can do on its own, not only relying on various expertise and support to drive this work, but then coming together and able to form an advisory committee made up of such passionate members who offer lived experience, work in the field and in different areas, including working with somebody such as Mo Korczynski, who's quoted on this slide, who's an executive director of a peer-led organization that supports people who are being released and transitioned back into the community. She works specifically in British Columbia and has lived experience. And, for her, and we hear this from so many others, she's consulted so many times from her perspective, but, what really comes of the information that she shares, and that, nobody's looking for another report that will just be sort of released and then sit on a shelf. It's really about underscoring the action component of the action plan, which leads us to where we are now in the time and effort that we've put into developing an action plan, hearing the calls and from previous work in areas that led us to where we are today, to develop an action plan on mental health and criminal justice for Canada, one that aims to support the mental health of all individuals who interact with the criminal justice system by recommending actionable changes at the individual, institutional, societal, and systemic levels. So we did outline sort of the core audiences for this action plans, with the focus primarily on justice-involved individuals, such as those who are incarcerated, as well as individuals who work within the system, so that we have more of that broader approach from both angles, and knowing that there's such interconnections there. And where possible, we're also taking into consideration other groups that often feel overlooked, including victims and survivors of crime, as well as families. So the main goals or aims of this work, we kind of tried to put into 5 areas of focus, including diverting people living with mental illness and substance use disorders from the criminal justice system wherever possible, supporting the mental health of justice-involved individuals at all junctures of the criminal justice and forensic mental health systems, providing continuity of care and support post-release, supporting the psychological health and safety of individuals working within the criminal justice and forensic mental health systems, and addressing, where possible, legislative and other system-level change that are critical for reform. The action plan also emphasizes the need to address and challenge stigma associated with justice involvement, as well as added stigma of living with a mental health concern or illness. And so, as mentioned, we do rely on a number of expertise and sort of a broader consultation and input where possible, but having worked closely with a core development advisory committee, certainly also some core project advisors, including Catherine Latimer, who's been working on this with us now for a number of years, and then a broader committee of various folks. We have about 20 or so members from a variety of backgrounds and expertise that are working with us and informing and guiding this work with us, including people with lived experience in the criminal justice involvement scenario, as well as with mental health and mental illness, individuals working within the criminal justice system, including a judge, lawyer, and union representation, correctional officers, and probation and parole officer representation, and then organization and individuals representing perspectives of First Nation, Inuit, and Métis, and other populations, priority populations, including African, Caribbean, and Black communities. So we have been working on this for quite a while now, and very, broadly have it broken down into 4 phases, and really just quite thrilled to be past even sort of the phase 3 and the phase 4 being it complete and having a final and released action plan. But with that, first having put time, quite a bit, kind of behind the scenes time into planning, creating relationships, establishing the advisory committee, and really landing on the core scope of the action plan, which is still quite broad at times. And then moving into phase two, that went into informing the action plan through various research and engagement activities that I'll speak to in a moment. And then phase three being well underway, which is amazing, and a big thanks to Christopher and his team as well, that with all the information collected in informing this phase to be analyzed and synthesized, which definitely was a big chunk that was then passed to Christopher's team to now have an actual action plan, which is such a huge milestone for us, and having something tangible for us to be looking at and getting some ongoing perspective on as we look to validate the content and get feedback to ensure that it's relevant, accurate, and then there isn't any major gaps. So then we'll be looking to incorporate the feedback that's happening as we have a strategically targeted review period to then finalize the action plan. And with that, looking to release later in next fiscal year, I'll just say at this point, have a soft launch and then ongoing engagement so that we can further understand the pieces within the action plan and where we can enable action with that work. So just some of the key activities that help to inform the plan, how we could do this as high level as possible, just to get a sense of the different aspects of work. Two research reports looked at national and international frameworks and strategies. One focused on the mental health needs of justice-involved individuals, and then the other one was focused specifically on the psychological health and safety of individuals who work within the criminal justice system. And also work related to law reform included a high-level scan of literature to see what academics were writing about proposed legislative reforms, as well as a scan of provincial and territorial mental health legislation to inform model language that provinces and territories can then look to incorporate in their respective mental health acts. In addition to the various literature and information was collected through engagement. So we did do a high-level national survey that was distributed to as much of a diverse perspective as possible, looking at key issues and barriers, as well as opportunities and promising practices in mental health and criminal justice. We held regular meetings with our advisory committee, and within that broader committee, we also had smaller working groups to focus on different aspects of the action plan, and again, to filter in more promising practices and really try to hash out what the key issues were to get towards the final content and recommendations. And then throughout this time, we've been socializing this work and continue to do that through knowledge exchange opportunities, speaking engagements such as this to just generate awareness as well as gain input and hopefully support and buy-in along the way as we move towards having an actual action plan available for everyone to refer to. So we're at this exciting time now where we actually have a tangible draft action plan that is under review, and we're working with certain folks to provide opinions. We'll be engaging high level with you folks today as well. But that's based on all of the information that we've been gathering over this time to consolidate and somehow magically through Christopher's team having one document report to highlight all of this, including recommendations. And with that, I'm happy to pass it over to Christopher now.
Thank you very much, Sandra, and thanks for the overview, Catherine. Thanks so much for inviting us to be here today. As Sandra said, we were handed a whole bunch of information about a year ago now, and we have spent many, many months piecing that together, coming up with a framework around how to present this. And we're really pleased, as Sandra said, to get a draft out there to the world for review. So I'm going to walk you through some of the structure with a couple examples. So I'll move to the next slide here where we detail that the action plan is structured around 3 key strategic pillars. And each of these pillars represents a different stage of justice involvement and guide the approach to addressing mental health at each of these stages. And I've actually heard this theme a few times already. So the first one is called care, not criminalization. And for this, we define it as everyone in Canada should have access to services and supports that prevent justice system involvement. We detail the social determinants of health and the importance of upstream prevention. And we also define it as people living with mental illness should be diverted from the criminal justice system whenever possible. And so the second pillar we call care during justice involvement. People in the criminal justice and forensic mental health systems must have access to high quality, evidence-based mental health care, substance use services, and social supports when and where they need them. These services should be trauma-informed and culturally adapted to meet the needs of everyone in these systems. And then finally, our third pillar is called care after justice involvement. We heard this before earlier about transition in care. People leaving these systems deserve continuity of care along with seamless and integrated mental health, substance use, and social services such as housing, employment, and income. And I think everyone on the call here today knows the needs, those needs very, very well. So as Sandra mentioned, these pillars are based on extensive research and consultation and real-world challenges faced by justice-involved individuals. We feel it provides a nice sort of framing structure for the action plan. Now, to bring these junctures to life, though, these pillars to life, in the next slide here, we've identified critical junctures or key moments in the justice process where meaningful interventions can and should take place. This juncture mapping was adapted from various similar models in the field. Many folks would probably see something along these lines out there in criminal justice world. But after synthesizing and organizing all of the issues, as Sandra said, we land on 8 specific junctures, and you see them here. So 4 of them land in the first pillar, care not criminalization. 3 of them land in the second pillar, care during justice involvement, and 1 in the last pillar called care after justice involvement. And I'll go through one of these in detail. So for example, under the care during justice involvement, there are multiple recommendations related to the institutional custody juncture you see there in the middle, including improvements to healthcare delivery, and the action plan details the need for primary, intermediate, and intensive services within correctional settings, removing systemic barriers to mental health care, and strengthening community connections to support rehabilitation. This is just a snippet of some of the issues that show up here. And so the action plan, as Sandra mentioned, also includes a section on supporting the psychological health and safety of workers, and I'll come back to that in a second as well. Now, the action plan has many, many themes, and we wanted to summarize a few here today, but of course, when you do see the full draft, you'll see that there's much more to it. But these are just a few, and I'll focus on these ones today. And first, one of the main themes that we saw over and over is the need for trauma-informed care. Given the high prevalence of trauma among justice-involved individuals, trauma-informed approaches must be embedded throughout the health and justice systems. However, we also know that trauma-informed care is not enough. We need the prevention aspect and to prevent trauma and to prevent a lot of these issues from occurring in the first place. So there, again, there's a big focus on prevention. The second challenge, or the second thing we learn, is the challenge in the access to services. Too often, people struggle to find culturally appropriate, timely, and effective mental health care at every stage, before, during, and after justice involvement. And so the action plan details ways of overcoming these challenges. And there's also a need, as we learned, for strong distinctions-based services, mental health, physical health, and social services tailored to specific populations, including Indigenous peoples, racialized communities, and disabled people, and all of whom face unique barriers to care and unique needs while in the justice system. And the fourth theme that we found, and this is again throughout the entire action plan from the beginning on to reintegration, is the need for off-ramps or diversion opportunities that prevent people from becoming further entangled in the criminal justice system when we know and the evidence suggests that mental health services and social services and supports would be far more appropriate. And finally, we saw the need, and we hear loudly the calls nationally for better data and metrics. Sharing data across provinces and territories can improve service delivery, help us set benchmarks of care, and enhance health outcomes, obviously while ensuring privacy protections remain in place. And as Sandra mentioned earlier, and I articulated, there's on our next slide, we talk about some of the themes related to people who work in the criminal justice system. And we did a different review for the commission last year on this. And the action plan focuses on supporting the psychological health and safety of people who work in the system. And while each occupation, of course, has different needs and they do different tasks within the criminal justice system, there are common strategies to support people. And those are, as we learned, implementing mental health training in workplaces to reduce stigma, encourage help seeking, prepare for traumatic incidents, reduce harassment, and promote trauma-informed approaches. We also want to ensure a full range of mental health services, including psychological services and supports, assessment, and peer support. We heard loud and clear the need for peer support. addressing workplace culture and structural barriers to psychological health and safety. So exposure to traumatic events, either directly or vicariously, can lead to compassion fatigue, burnout, moral injury, stress, and other injuries, as again, folks know really well. And yet trauma is often seen as, quote, part of the job. And this is a big cultural norm that we feel needs to be challenged. So however, what the action plan notes, though, that workplace strategies are not enough. While training and education have tremendous value, they cannot replace comprehensive organizational policies and supports. So relying solely on individual strategies can sometimes place the burden on workers rather than addressing systemic barriers to healthy and safe workplaces. So we detail a few ways of addressing this through system-level strategies, including addressing chronic underfunding and understaffing in correctional environments, providing comprehensive employer-funded mental health services, and as I mentioned, across the continuum of services from psychological supports to peer support, reducing exposure to workplace violence through protective interventions. That helps to support people who work in the system, and that helps to support people who are just as involved. So there's this mutually beneficial role of addressing workplace violence. And finally, embedding specialized mental health clinicians in workplaces has been shown to help create psychologically healthy workplaces. And of course, as I mentioned earlier, this is just a quick overview of the themes, and the action plan goes into much more detail. And so on the final slide, I did want to provide an example of how the action plan structures the issue statements and recommendations. And there's a total of 70 recommendations so far. That might change through the review period coming up. But this is how it's organized. One key issue, for example, if you see there on the left, is the lack of timely mental health screening, assessment, and access to pretrial diversion programs. And so we list a recommended action, which is to expand access to expert pretrial assessment and ensure routine early screening. And then to support this, the issue and the action, we identify conditions of success, such as increasing the number of mental health professionals available for pretrial assessments and providing clear pathways for legal professionals to refer individuals and help divert people to programs in the community and to the appropriate community supports. Now, each issue and action in the action plan also includes a background section, which details some of the context and the issue and why that's important for the action plan. We also, as we heard, detail equity considerations for the priority populations identified by the Commission and the folks they've been working with, as well as we list promising practices across the country that could be either scaled or expanded up, or in some instances, evaluated and potentially expanded. And then what we're working on now is outlining measures of success. So looking at metrics and ways of supporting the implementation of these actions across the country. And we'll be working with the Commission over the next few months to do a bit of an implementation map of how do we measure the benefits of these actions if they were implemented, and who's involved in the implementation of some of these recommendations, and who are some of the people who can help make this happen. And so that is how the action plan is currently structured. It's been really fun piecing it all together. And of course, there's way more details in the document. So that's what I have for now. So I'll pass it over to Sandra to close things out.
Thank you, Christopher. And I think we are sort of just wrapping up our allotted time for this, but yeah, just moving into what's next in our current priorities, are working through this review period with targeted input that we're seeking out, including some focus groups with Indigenous folks to review closely and give their feedback, as well as other expertise and perspectives, and then looking to work through all of the feedback that we gather from the draft to then actually finalize the action plan. And sort of in tandem with that, we're already working through communication strategies, not only to socialize and work through this action plan, but also alongside continuing to work through anti-stigma and the components to that, and where we can support other anti-stigma work happening in this area, and certainly looking for you folks and others, and how we can support that more collectively moving forward as well. And then also just something else that we've already been doing over the past several months with quite a bit of success is the government relations engagement. So again, awareness of the work that's happening, and in continuing to work towards ongoing engagement, as well as hopefully with you folks as well as this work progresses, and that that we can have that not only awareness but buy-in of this work to ultimately enable action moving forward. So with that, I think I'll wrap up our time. The last of our slides are just acknowledging Q&A and also maybe just jumping to a thank you, because I know there'll be more discussion to come, but there is information on our website. And then we do have sort of a generic justice@mentalhealthcommission.ca email that you can reach out, and we do monitor and respond to it, or certainly can reach out to us directly. So with that, I'll pass it back to Sheila.
Thank you both so much for this presentation on the enormously ambitious and important work that you've been doing with the Mental Health Commission of Canada. I know that folks will have thoughts and comments, feedback, and I know you're excited to hear that during the breakout sessions. So please, folks on the line here, do hold those thoughts and that feedback. And we're so excited to have you be part of this conversation. But now we turn the electronic podium over to Jeanette Clark. Jeanette, are you there? You are. Excellent.
I am.
Turn it over to you. Thanks.
Great. So I'll also attempt to share my presentation. So really happy to be here, and thanks for the opportunity. It sounds like you guys are having some great discussions over a number of different sessions. So really pleased to be here today. As I mentioned, Jeanette Clark with Correctional Services Canada. I work in our health services sector in my role in accountabilities for health policy and programs, but have worked with CSC for a number of years, and primarily in the field of mental health, and in the last few years, health more broadly. So I'm gonna try to use the time today to give a little bit of an overview of the services we do provide, as well as a population profile, and then a little bit of work that we're doing in terms of our priority areas to improve our health service system for those who are incarcerated in our federal system. I would just like to highlight, I think I'm sure it's a knowledgeable audience in terms of our mandate, but I'll just maybe give a little bit about that in terms of Correctional Services Canada's role in terms of providing health services to individuals who are sentenced to 2 years or more and are in our federal institutions. We have 43 institutions across the country, as well as healing lodges, and then offices in the community to support offenders as they transition into the community. In particular, health services, there's a legislative mandate for Correctional Service of Canada to provide essential health care and reasonable access to health care that's in keeping with professionally accepted standards. So that legislative mandate is really what guides our work. And we've been really fortunate over the years to continue to evolve and expand our health service delivery system for patients in all of our institutions across Canada. And a little bit about our model of care is it is consistent with the World Health Organization's continuum of care. It really is patient focused. It is based on interdisciplinary health care. So we have a range of health professionals, including psychiatrists, physicians, psychologists, social workers, nurses, occupational therapists who work in all of our institutions to provide health care. And that aligns with our obligation to provide health care that meets professionally accepted standards. Another indication of our commitment to that mandate is that all of our health services are accredited by Accreditation Canada, and that is the same program that would accredit or evaluate any healthcare system in Canada or even internationally. So we're really pleased that we have that accreditation status and have maintained it over a number of years. We have continued to make some improvements to our health service delivery model and refined our health service delivery model. And in particular, for mental health services, we've been really fortunate over the last decade to enhance our whole model of care. So we really provide health services to patients right from intake to their release in the community, with some opportunities for health service provision at select sites in the community. And what that really looks like is we have a primary level of care, which would be just the kind of care you and I would get in the community if we saw a family doctor, a nurse practitioner, an OT or social worker, psychologist, if we had health conditions that were impacting us, but we we're still able to kind of maintain our activities of daily living and able to get through our day and just needed some support with health conditions. So our interdisciplinary team provides primary health care at all of our institutions. In addition to that, we have regional treatment centers, 5 across the country. Those are designated hospitals that provide psychiatric level health services in 5 sites across the country. One of those is the Regional Psychiatric Center in the Prairie Region that provides that level of care to men and women, and our other 4 provide those services to men only. And that would be people who do need sort of a hospital level of care, whether that's for acute psychiatric needs and stabilization, or more significant mental health needs that they can't quite function or manage in the mainstream institution. And we also use those institutions to provide more long-term care or alternative people who have alternative level of care needs, sometimes older patients who might need more support with activities of daily living or more direct care in their day-to-day lives. In addition to that, we also have intermediate care. So at some sites across our country, we have dedicated mental health teams, and they provide, much like you'd see in the community, a sort of a day treatment program. So they're individuals with mental health needs that are a little higher than maybe the primary care and how you can live in your own community and get things done. Don't quite require a hospital level of care, but need a little bit more intensive services or support from a dedicated team, just to enhance or address mental health needs and functioning. So our whole continuum of care is available, quite specific to mental health. We do support release to the community with discharge planning services. And at some communities across the country, we have nurses, psychologists, and social workers who work in particular with patients with, severe, significant mental health needs to support their transition and continuity of care as they transition into the community. I'll just mention our population health profile, and I'm sure, again, some of this has been referenced in terms of the increased prevalence of mental health needs and substance use needs among individuals who are incarcerated in the CSC population, and the numbers sort of speak to themselves. I'll also mention we have been doing a lot of work in our system lately to look at how we're doing as a system and performing as a system. And we have just worked on a report card, much like we see other healthcare systems develop, very similar to what CIHI has produced, that looks at our delivery of healthcare with key indicators and how that compares to the community. And I'll just highlight a couple things. We have made a dedicated effort over the last a year and a half to enhance and strengthen our primary care model. So we've introduced a model that's called the Person Health Care Home model. It's based on the World Health Organization, a patient medical home, a model that's been endorsed by the Canadian Physician Association and Medical Association. And it really looks at integrated care for individuals that brings together the whole team, who puts the patient at the center, in terms of what their needs are, what the individual's needs are, and has the team sort of respond to those needs in a collaborative way. So as part of those efforts, we've increased some of our access, ensuring that 94% of the individuals in CSC have an identified most responsible physician. So the physician who sort of has a lead role in their care on a day-to-day basis. In addition, we also have 95% of individuals with mental health needs who've received mental health treatment in the past, compared to 92% of the general Canadian population. So when it comes to access to mental health services, we are, meeting or even exceeding a little bit some of what the general Canadian population would see in terms of access to that service level. I'll mention, I know there's a bit of a focus and discussion in terms of working with individuals from a trauma perspective or individuals with personality disorders. Again, our efforts try to be person-centered and trauma-informed. We've been trying to support that from a treatment perspective in terms of, skill building or intake assessments, or, providing more direct or acute services as needed. In addition, our healthcare professionals attempt to use techniques in their interviewing and working with patients to assess and work with them in terms of their readiness for change. And I would also highlight, though not written here, we have been trying to deliver training or workshops to staff in collaboration, often with the Royal Ottawa Hospital here in Ontario, to really highlight some specific professional development opportunities connected to mental illness and mental health, and sort of responding to patients' needs, including bringing a trauma-informed approach. So where do we go from here? Of course, in healthcare, it's all about quality improvement and trying to improve our system. So I'll highlight just quickly a couple of key initiatives that we're trying to work on to improve our health service delivery model. In the spring, we'll be implementing a patient advocate service. We intend to hire healthcare staff at our women's sites, at our maximum security sites that have intermediate mental health care, and at our regional treatment centers, so those psychiatric hospitals, who will really be healthcare navigators, who will work with the patient to help them understand the healthcare system within CSC and navigate it, to be aware of their own responsibilities, roles, rights, and access, and be able to communicate their healthcare needs, and to help to advocate and navigate in a way that helps them get timely access to services that are patient-centered and responsive to their needs. Another thing I'll highlight quickly is we are doing a comprehensive review of our regional treatment centers. A part of that review is looking at the population health needs at our treatment centers across the country, ensuring no matter what treatment center you're at within CSC, you do get sort of standardized, consistent services and programs. And really, how do we ensure we're supporting patient access in a way that maximizes the treatment outcomes? We're doing the same kind of work for our intermediate care units. We were really fortunate a couple of years ago to have our national senior psychiatrist, Dr. Colin Cameron, lead a review of our intermediate mental health care units. That came with a number of recommendations. So we're looking to implement some of those right now, again, with a focus on making sure people who have that level of need are admitted to those units, that we're using those units as fully and effectively as we can, and that there's standard consistent services that a person at any one of those units across the country would get if they are admitted to that unit. Another thing we're doing is we're implementing 24/7 nursing at institutions that have these units, in the effort to really help respond to urgencies or crisis, in particular support response to mental health needs, in the evening and nighttime. Some of you might be familiar with CSC structured intervention units. And so these are not dedicated healthcare units, but we know health services and health professionals have a key role in working with individuals who are in structured intervention units. So we have very specific requirements in terms of monitoring and assessing on a daily basis the health of individuals in SIUs, and then at a structured time frame doing more comprehensive mental health assessments. And again, our role there is to really be responsive, to monitor people's needs, and connect them with the appropriate healthcare service they might need, depending on how that changes. And just one more thing I'll highlight is our community mental health work. So as I referenced sort of some of the good work that's been shown in our report card in our service delivery. One of the areas for improvement for CSC Health Services is continuity of care at points of transition. And that means two things. It does sort of mean moving from institution to institution, but it also means supporting that transition to the community. So we have been doing some work to understand the patients we're seeing or the offenders we're seeing as they transition to the community. How can we coordinate and support those services more consistently? And most importantly, how can we support the continuity of care so that those individuals, when they return to their home community, can access a healthcare team that's local and who will manage and work with them on their healthcare, in the long term. So again, we'll continue to work on these priority areas, engaging with experts and stakeholders such as yourself. I know time is short, so maybe I'll stop there. But again, happy to answer any questions as we move forward.
Jeanette, thank you so much for that. Once again, a very comprehensive presentation, and I'm sure people will have all kinds of feedback and questions afterwards as part of a recent technical committee of the Health Services Organization creating a new Accreditation Canada standard for CSE. I'm very eager to see over the next number of years how the standard chimes with the kinds of initiatives that you're describing. So thank you again. I want to now turn our attention to Riley Hunt from the John Howard Society of Newfoundland and Labrador. Riley, are you there?
I'm here. Thank
Hello,
you.
welcome.
Thanks for having me. Just bear with me one moment there while I halt my presentation.
I'll just say while you're doing that, it's lovely to have another person from Atlantic Canada presenting today.
I'll echo that with my Newfoundland accent.
Excellent, yes.
I apologize. I'm just having some technical issues here. If you bear with me just a moment.
Riley, I did put it up if you want.
All right, perfect. Well, I guess we'll roll with that. I apologize for holding everything up there, but thank you again for having me. So I'm Riley Hunt. I'm with the John Howard Society's New Day program here at the Newfoundland and Labrador chapter of the society. I'm going to be giving an overview of the program itself and the services that we offer to some of our participants that are involved in the criminal justice system here in the province. So I guess before I get into it, just a brief history of how we came to be. Back around the 2008, thank you. Back around 2008, it was identified, I guess, that we needed to conduct a panel review of the operations of the adult correction system here in Newfoundland and Labrador. And the goal was to make recommendations on policies and procedures that would improve the conditions of the correctional facilities here in the province. One of the key things that was identified from this process was the need for stronger partnerships and continuity between the correctional institutions themselves and community reintegration. So primary recommendation that came out of this was for community organizations to partner with the institutions themselves for addressing the individual reentry needs. What was born out of that was the Justice program, which was initially delivered through the Canadian Mental Health Association here in the province from 2009 to 2022. In late 2022, the John Howard Society Newfoundland and Labrador was notified that they would no longer be offering the program, and we were fortunate enough to get the opportunity to provide those services through our organization. So that started towards the end of 2023, and we've been trucking along ever since. So I guess, to really define, what New Day is. So New Day is a case management service for individuals that are involved in the justice system and looking for supports for their reentry back into the community. Primarily, we receive referrals from Her Majesty's Penitentiary, which is our largest correctional facility here in the province. And it is based in St. John's in the capital city. And we try to provide case services to individuals who are living with significant and or persistent mental health issues, or those that have concurrent disorders. We try to integrate a trauma-informed approach, and the intensive case management team assists participants that are currently in custody to develop, comprehensive support plans to improve community functioning, quality of life for when they eventually do get released. Our team is made up of a few key roles. So we have a lead intensive case manager who is myself. My responsibility is to provide consultation to the New Day team for case management purposes, as well as planning and providing intensive case management to individuals on my caseload. I also have my colleague, who I believe is watching right now, so shout out to Jen, who is our other intensive case manager. Her responsibility is to carry a caseload of 10 to 15 participants, which would be the same capacity for myself, and to provide intensive case management through both in-reach at Her Majesty's Penitentiary and in the community. And we also have our community support worker, who I believe is also watching right now, so shout out to Jacob for all the amazing work that he does. His responsibility as community support worker is to provide support to the case management plans as outlined by the intensive case managers. And it can include, but it's not always limited to, such needs as like transportation, conducting life skills workshops, therapeutic rec activities, and so on. I'll also add, though it's not in the slideshow, we recently were fortunate enough to have a peer support worker join us here at the John Howard Society, who has become a large part of the New Day team, who has been able to provide some of his own lived experiences in the criminal justice system to provide insights to both staff and participants who are trying to navigate, the reintegration process. Some of the key values of New Day. So we try to work from a trauma-informed case management approach, and really lean into strengths-based assessment and evaluation. I think it's really important to, keep the focus on the strengths that each participant has, and make sure that the service delivery is very person-centered and tailored to them. We also try to, of course, keep a focus on privacy and confidentiality, emphasize advocacy and social justice, and work towards things such as, healthy communication, relationship building, setting healthy boundaries, and gaining independence. We do some goal setting with all of our participants, which I'll discuss a little bit further into the presentation. But we try to keep that participant-led as well, and try to encourage them to identify their own goals. So just some of the eligibility criteria for the program. Right now, to become involved, we're working with individuals that are ages 18 and older, who have a confirmed or suspected psychiatric history of significant functional impairment. This is really significant because I think there's a number of individuals that really struggle with their day-to-day functioning, or mental health challenges in general, that may not be able to get adequate access to medical care to receive a formal diagnosis. And we really want to make sure that having that confirmation was not going to become an obstacle in terms of participating. So we do accept individuals that may just have suspected psychiatric history, or significant functional impairment. Individuals typically would be experiencing challenges in just their day-to-day life. Different things like participating in life skills, working towards doing day-to-day tasks, taking medication, getting to appointments, and so on. We also work with individuals who are currently incarcerated with a minimum of 2 months remaining on their sentence. And we do accept remand referrals, individuals that may not be sentenced and don't necessarily have a release date. We try to work with them in advance as best as possible. The program is entirely voluntary, with the goal that ultimately individuals would be setting goals and participating on their own accord. We don't force anyone to be in the program, and we don't generally accept referrals that are coming from other sources whereby someone's being mandated. So, for example, if someone is being told by a probation officer that they have to participate in the program, we generally try to focus on the referrals of those that are willing and interested in being involved. And lastly, they'd have to be residing in the St. John's area. Referrals are accepted from classification officers at Her Majesty's Penitentiary, mental health and addictions team from the Newfoundland Labrador Health Services, and community agencies, or agents of the court system. We also accept self-referrals whenever possible. We encourage anyone that's interested to in becoming involved to consult their classification if they're currently incarcerated, but we certainly try to get every opportunity to accept those directly from the source. So this, I guess, is a little bit of an overview of the process for becoming involved in the program. So the participant would consent to a referral to the New Day program. And following that referral, we arrange an initial assessment, which goes over the clinical and social needs of the individual. And we really try to identify, the areas of support that they require, and what the New Day team can do to meet those needs. We then move on to screening and accepting them into the program. And while they're still incarcerated, we provide in-reach services to discuss transition planning and getting them connected to mental health and social supports. A lot of what the in-reach stage of the program looks like is really just building relationships and connection with program participants, and making referrals and doing the necessary prep work for their upcoming release. When the participant is eventually released from custody, they would be connected with intensive case manager. who would try to meet with them regularly to establish, their needs and set goals that would be reviewed on a weekly basis. The program then goes on for approximately 12 to 18 months, depending on the individual's needs. And during this time, we try to help participants work towards achieving independence and an eventual release from the program. During the in-reach and transition planning period, we try to hold one-on-one sessions where we just come up with solution-focused discussions, I guess, for exploring the individual strengths and their needs for when they get out, how their existing strengths can act as a tool for helping them navigate the challenges that lie ahead with reintegration. Our community support worker will generally try to visit the individual as frequently as possible and engage in healthy social interaction. And during this time, we'd also start applications for things that are often needed when people are being released. Primary things include, IDs, health cards, housing applications, referrals to treatment centers, and so on. During this transition period, the intensive case managers during this transition period, the intensive case managers would continue to run through case planning meetings and identify complex needs that may require attention as the individual explores that transition. Plans and goals are identified and put into place with the individual so that hopefully when their release date comes, they are met with some support. I don't mean
to, Riley, and this is in the spirit of just such enthusiasm for this important work that you're presenting. I see it's just a couple minutes after 3, and I know you were cut a little bit short, but if you could wrap up I'm so sorry, but in a minute or so that the breakout groups could start, that would be wonderful. Thank you so much.
Yes, of course. So overall, I guess the program really aims to create some continuity between exiting incarceration and re-entering community. We try to create a bit of a bridge so that an individual is not left to figure things out on their own once they walk through those gates. Because as we know, there's many people that don't have supports in place, whether formal or informal supports. And oftentimes, I think they really rely on having, the knowledge and expertise of the staff at the New Day program to help them navigate the system for setting them up for success. But also, I think it's important that they rely on the relationships that we build and that real human connection, so that they have someone to rely on when they're in community. I'll leave it there, but thanks so much for having me.
Thank you so much, Riley. And I'm going to be stepping back in just a moment, and I'm going to invite Catherine up to sort of wind up this panel. But let me just say for myself how moving and important I've found this journey that you folks have taken us through, from the very high level ambitious work of the Mental Health Commission to that very grounded person level work, obviously systems work as well, that you just described, Riley, and the moving through there with some insights into the correctional system itself as it stands right now is incredibly profound. So thank you. And let me just see if Catherine is there.
Yes,
and
yeah, I'm here. Thank
Great.
you so much, Sheila.
Thank
I
you.
really appreciate it, and terrific panelists. And I think we all enjoyed it and learned a lot. I think we still have some hurdles ahead of us, but we'll plow on and see what we can do. For those of you who would like to stay and participate in the breakout sessions to provide more feedback or make your suggestions known, that would be fabulous. Just sit tight and we will be shifted into breakout rooms.